Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. This is the first episode of a three-part series about the 2021 ACR Vasculitis Foundation Guidelines for the Management of Systemic Vasculitis. It's the first time that the ACR has developed vasculitis guidelines, which were done in collaboration with the Vasculitis Foundation, the premier patient support organization for vasculitis in the United States. Over the course of 3 episodes, Dr. Sharon Chung, the lead investigator of the project, will guide us through recommendations, highlighting new or surprising conclusions, gaps in our knowledge, as well as instances in which the recommendations may not be applicable. Her insights into these guidelines, and more importantly, into the management of vasculitis, are invaluable. On today's episode, we'll discuss why the guidelines were created in the first place and what impact the authors hope to achieve as a result of these guidelines. We'll then dive into the recommendations for ANCA-associated vasculitis, including GPA, EGPA, and MPA. We'll address very controversial questions about rituximab versus cyclophosphamide for remission induction. We'll talk about the use for plasma exchange, whether you should follow ANCA titers, how long to continue remission maintenance treatment, the use of low-dose glucocorticoids, the role of mepolizumab in EGPA, and whether or not to adjust treatment for vasculitis in light of the COVID-19 pandemic. I think all of us, providers and patients included, will benefit greatly from what Dr. Chung has to say. So who is Dr. Chung? Well, in addition to leading this project, she's also the director of the Vasculitis Clinic at UCSF. She's also a researcher interested in exploring how genetic and epigenetic factors influence the development of autoimmunity. And now, on with the show. Sharon, welcome to the show.
Thank you. Great to be here.
So let's dive in. Why are guidelines needed in the first place?
Well, I would say for the following reasons. First and foremost, the vasculitides are rare diseases that have life-threatening, organ-threatening complications. Because they are rare, many rheumatologists don't have significant experience caring for patients with these diseases. And because since they have life-threatening complications, there is some fear in caring for these diseases and fear that if you make the wrong decision, patients might have poor outcomes. So the first goal of these guidelines is to somewhat alleviate the fear and give practitioners a roadmap to use to treat patients with these life-threatening complex diseases. The second is that thankfully, in the past decade or so, treatment options for patients with vasculitis have increased. So instead of just having prednisone and cyclophosphamide, there are now a variety of medications healthcare practitioners can consider when treating these patients. And we wanted to give these healthcare practitioners an idea of preferences for certain medications or considerations for when certain medications should be used. And lastly, this was actually a request by the membership of the American College of Rheumatology. Rheumatologists themselves asked the ACR to develop guidelines for vasculitis.
And what was the role of the Vasculitis Foundation in the development of these guidelines?
So the Vasculitis Foundation is the premier patient support organization for patients with vasculitis in the United States. They have been very interested in supporting these guidelines as well as disseminating these guidelines to practitioners in hopes that patients receive state-of-the-art care.
And have you noticed that is there variability in how people treat vasculitides across the country or across the globe?
There is definitely variability. Part of the variability is due to how you were trained and who trained you, and whether or not the person who trained you had certain preferences for certain medications. And there is also variability, perhaps not as much in the United States, but across the globe because of access to drugs. So there are certain medications that we're able to use more commonly in the United States, but practitioners in other countries may not be able to use because their access is not as easy to those medications.
So let's dive into the first guidelines about ANCA-associated vasculitis. And, I think in the paper, you guys grouped granulomatosis polyangiitis with microscopic polyangiitis together and then discuss EGPA or eosinophilic granulomatosis with polyangiitis separately, EGPA. So let's first dive into GPA and MPA. And, I can tell you, I was on service about a month and a half ago, and we had a 67-year-old woman who had been feeling ill for a few months and then presented with hemoptysis and acute kidney injury, was found to have, MPA, eventually actually had to be in the ICU. And one of the first questions that we were asked is whether we should give her rituximab or cyclophosphamide. And I feel like for every patient that I've ever cared for with vasculitis, thinking about rituximab or cyclophosphamide is always a challenge. How did the group think about that question and whether you came up with, some guidelines or answers about what to do with most patients?
So in this situation, the tried and true and time-tested treatment has always been cyclophosphamide. And with the advent of rituximab in the past 10 or plus so years, that paradigm has shifted such that in the United States, I would say more frequently we are reaching for rituximab now. Clinical trials show that rituximab and cyclophosphamide have essentially equal efficacy for patients with initial presentation for these diseases. When you think about relapse rates, the two medications have equal efficacy. Rituximab has been shown to have better efficacy than cyclophosphamide for patients who have relapsing disease, and that was shown in the RAVE trial. There are a lot of considerations when thinking about rituximab versus cyclophosphamide. In the guidelines, we conditionally recommend rituximab over cyclophosphamide for patients who have severe active GPA or MPA. And the factors which led to that include considerations for efficacy, considerations for toxicity. So those of us who have used a fair amount of cyclophosphamide recognize its effects on the bone marrow with leukopenia, the infectious risks, the malignancy risks, the fertility risks, especially that accumulate with increasing our cumulative dose of cyclophosphamide. And it's really because of the toxicities of cyclophosphamide that led us to conditionally recommend rituximab over cyclophosphamide. I will also say that we had a patient panel as part of our guideline development effort to, ascertain their preferences and thoughts about various treatment recommendations. And the patient panel also preferred the use of rituximab over cyclophosphamide.
So how do you think about sort of treatment for vasculitides? It seems like we're treating them somewhat similar to cancer, right? Where you first try to get them induced into remission and then you maintain remission. So is that how we should be thinking about the treatment for vasculitides as well?
I don't know if this is a carryover from using cyclophosphamide as our initial treatment for vasculitis, because cyclophosphamide was developed as a cancer chemotherapeutic agent. But especially for the ANCA-associated vasculitides, we do think about two treatment phases. We think about the remission induction phase, and we think about remission maintenance. And so for remission induction for severe GPA or MPA, we think about rituximab and cyclophosphamide, and the guidelines have a conditional recommendation for rituximab over cyclophosphamide.
Should we think about plasma exchange? That was one of the discussions, hotly debated discussions we had in the ICU. Us, the nephrology team, the pheresis team, the ICU docs is, should we pherese our patient or not?
I don't know if I am running where angels fear to tread. So this continues to be a topic of debate, primarily because the Pexavas study, which came out, was a randomized trial of plasma exchange versus no plasma exchange, large study, international, essentially showed that there wasn't any benefit for plasma exchange when looking at a combined endpoint of death and end-stage renal disease. Now, there's a certain quirk about combined endpoints. They could technically increase your power in a study, or if one of the endpoints truly isn't different between the two interventions, they could kind of dilute the effect of the other considered endpoint. And what happened in the Pexavas study is that there did not seem to be a difference in death between the plasma exchange or no plasma exchange arm, but there was a suggestion of a decreased incidence of end-stage kidney disease between the two arms. The literature review group supporting these guidelines actually conducted a meta-analysis between multiple studies looking at plasma exchange in ANCA-associated vasculitis. And to summarize the results of their meta-analysis, it actually suggested that there was a benefit for plasma exchange at decreasing end-stage kidney disease in GPA and MPA, but that benefit was most pronounced in individuals who had a higher risk of end-stage kidney disease. So your patient coming in with renal involvement with a creatinine of 1.5 probably is not going to get that much benefit if you do plasma exchange. But, your patient coming in who 2 months ago had a normal creatinine and is now being admitted to the hospital with a creatinine of 5 with hematuria and proteinuria, that patient may actually have a benefit from plasma exchange at decreasing their risk of end-stage kidney disease. The other aspect of plasma exchange, though, is that you have to balance the risk. And so there was a suggestion of risk of increased infection with plasma exchange. I think as a guideline group, we would not recommend plasma exchange for all comers with glomerular nephritis. But for those who have an increased incidence of end-stage kidney disease, for example, they're coming in with acute rapidly progressive glomerular nephritis with creatinines of 4 or 5, that might be a person where you could contemplate doing plasma exchange.
And then I think the other caveat was in patients with anti-GBM disease that I think plasma exchange seems to be the sort of the standard.
So there is a small percentage of patients who are ANCA positive who also carry anti-GBM antibodies. Those patients should get plasma exchanged, irregardless of what their entering creatinine is.
In addition to rituximab, cyclophosphamide, plasma exchange, part of the remission induction treatment is always steroids. We love steroids. Are there any guidelines about the use of steroids in remission induction in these patients?
I would more say we have a love-hate relationship with steroids. But yes, I think one of the main messages coming out, not just from the guidelines for ANCA-associated vasculitis, but also large vessel vasculitis and PAN, is the idea that we really should be limiting or minimizing our use of glucocorticoids as much as possible these days. So much of the toxicity our patients experience is due to glucocorticoid exposure. We handle that in the ANCA-associated vasculitis guidelines by recommending the reduced dose glucocorticoid regimen that was used in Pexavas. Unlike kind of debates that rage on about plasma exchange for that study, the results for the reduced dose glucocorticoid regimen were pretty set, pretty certain, in that the reduced dose glucocorticoid regimen was really non-inferior to the standard dose glucocorticoid regimen, had a statistically significant decrease in the rate of infections in the first year of therapy. So we should definitely use a reduced dose glucocorticoid regimen. I think the challenge is once you start glucocorticoids, the question is, when do you end them? And unfortunately, we don't have a good answer to that one. That is, how long to keep a patient on glucocorticoids is really dependent on the patient's disease course, patient preferences, and physician preferences and experience.
I think that's so encouraging that we're thinking about optimizing treatment, not just, preventing death, right? So the fact that we're discussing lowering the amount of immunosuppression we're giving patients suggests to me that we're getting pretty good about managing these conditions. And now we're even thinking about reducing toxicities, which is pretty fantastic.
I think one of the, extremely exciting developments in the past few decades in vasculitis treatment is exactly what you said. In the past, our main focus was how do we keep our patients alive? And now we've moved beyond that because we have good therapies to keep our patients alive. And so the question is, how do we optimize treatment and minimize toxicity for our patients?
And you mentioned the same thing with cyclophosphamide. One of the reasons why the group favored rituximab was also the decreased risk of adverse, long-term effects from cyclophosphamide, which is great. All right, so my patient is out of the ICU. She's actually survived and doing fairly well. How do I think about remission maintenance over time? What are the suggestions for medications?
So we now thankfully have quite a number of options for remission maintenance therapy at this time. Options are rituximab, methotrexate, azathioprine, CellCept, leflunomide, and others. I think clinical trial data pretty unequivocally shows that rituximab has a decreased rate of relapse compared to azathioprine. That has been shown in the Manritson studies as well as the more recent Ritazaram study. And their past studies have shown that methotrexate is relatively equivalent to azathioprine for remission induction. And other studies have shown that CellCept or mycophenolate mofetil has an increased rate of relapse compared to azathioprine. So we end up doing this somewhat transitive property of efficacy where we think about rituximab is first-line therapy because it's associated with the decreased relapse rate. The next agents would be methotrexate and azathioprine, and then the agent after that would be CellCept or mycophenolate.
So we're getting patients. And should we be trending ANCAs in order to determine when to give the next dose of rituximab? Or should we just say, hey, it's been 6 months, let's give you another dose?
I think there's an underlying question to that question, which is, are ANCAs useful for gauging disease activity or tendency to relapse? Or other laboratory studies like CD19 B cell counts useful for gauging tendency to relapse? And I would say overall, the guidelines committee favored scheduled dosing over using laboratory markers such as ANCA titers or B cell counts to guide dosing. One of the reasons is that there's an overall feeling that ANCA titers are not necessarily strongly predictive of disease flares and aren't necessarily great indicators of disease activity. And the same goes for B cell counts, that we've all had patients who've had disease relapses when their B cell counts were undetectable. And therefore, perhaps we should not be basing therapy on those factors which aren't great indicators of disease activity. So overall, in the guidelines, we recommend scheduled dosing. Now, there are situations, and this is just in my own clinical practice, there are situations where I would consider employing these other alternative dosing strategies using laboratory studies. And those would be patients who've been on medications for a long period of time, where I'm, interested in minimizing their total medication burden, or they may have other factors showing some medication toxicity, such as developing hypogammaglobulinemia.
And which brings up a very timely point about rituximab. Rituximab for me used to be one of my favorite drugs. For the most part, patients tolerated it very well and it was very effective. But now there's recent data about the use of rituximab and COVID, both that it prevents the development of antibodies against the vaccine, and people that have been treated with rituximab may be having poorer outcomes should they develop COVID. So should we, in a patient who's in the ICU, should we consider COVID when we make our decisions about using rituximab, or does the data favor rituximab anyways?
I think this is a very complex area. So the options are cyclophosphamide versus rituximab for remission induction. And we know from past experience with cyclophosphamide that cyclophosphamide can cause B-cell depletion and prolonged B-cell lymphopenia. These are studies from, the 1970s with initial use of cyclophosphamide for GPA. So while I recognize there are definite concerns about rituximab use during the COVID era, I'm actually not sure what cyclophosphamide's impact as well. And then there may be the possibility, because of cyclophosphamide's effects on B cells, that cyclophosphamide may also impact, antibody responses and, overall survival outcomes in the ANCA-associated vasculitides. I think right now it's too early to say whether or not we should favor one treatment or another in the era of COVID. I think the usual precautions apply. All patients should be vaccinated, as much as they're able to. Patients should get boosters, especially if they're on rituximab. We are hoping that patients on rituximab do also develop some form of cellular immunity, cellular response to the vaccines. So unfortunately, this is a situation where time will give us more data.
I think another thing that you mentioned that is important is the fact that we're now using fewer steroids, which have also been associated with poorer outcomes. So trying to reduce the amount of steroids that people see may also help, should they develop COVID.
If anything, this is the time for us to try to minimize our therapies as much as possible.
How long do you typically keep patients on rituximab once they're on maintenance?
Or most of the trials have patients on remission maintenance therapy for 18 months, 24 months, something along those lines. And it's not because there's something magical that happens at 18 or 24 months. It's because all clinical trials need to come to an end at some point. So we really don't know how long patients should be on remission maintenance therapy. There are certain factors which are associated with risk of relapse. One of the primary ones is PR3 ANCA positivity. So patients who are PR3 ANCA positive have a higher risk of relapse. And obviously, patients who have relapsed in the past, we worry about them relapsing again in the future. So this is my long-winded way of saying we don't know how long patients should be on therapy. We recommend generally at least 18 to 24 months because that's what clinical trials implemented. For those patients who are PR3 ANCA positive with relapsing disease, we would generally recommend a longer course of remission induction therapy, but the actual course is going to need to be individualized for each patient.
Let's switch gears a little bit and talk about EGPA, because that was separated in the guidelines. How do you see EGPA different than GPA and MPA if they're all ANCA-associated vasculitis?
I think they all fall under the umbrella of ANCA-associated vasculitis, but EGPA is very much a different disease. Even though it's ANCA-associated, only about 40% of patients are ANCA positive. Most of the time it's myeloperoxidase. They have other disease manifestations such as asthma, and they also have other pathogenic cell types. There's a strong eosinophil component to EGPA. So even though EGPA, it falls under the umbrella of ANCA-associated vasculitis, it is its own entity. Many think of EGPA in some ways as two separate diseases. The patients who are ANCA positive tend to look more like GPA and MPA in that, they're more likely to have renal involvement or vasculitic manifestations. Those individuals who are ANCA negative tend to, have less vasculitic manifestations and more other manifestations associated with poor outcomes, such as cardiovascular manifestations. And so when we think about treatment for EGPA, especially when it comes to remission induction, there are some practitioners who put more emphasis on whether or not a patient is ANCA positive or not.
How does that change your management? So you have a patient with EGPA with severe disease. How are you going to induce them?
Just honestly, we got a lot of pushback for one of our statements for EGPA. For EGPA, we did not come out with a recommendation statement with regards to rituximab or cyclophosphamide for remission induction in severe disease. We came out with a statement that said you can consider either cyclophosphamide or rituximab. And there were some practitioners who were fairly unhappy with us for saying that, because they felt strongly that, for example, cyclophosphamide should be the preferred treatment because we have less data supporting rituximab use. We don't have randomized controlled data. I think this is a situation where you really need to look at the patient and kind of see what the patient has and see what treatment might be more appropriate. If a patient is ANCA positive with kidney involvement, that's a patient where I would really strongly consider rituximab, because we know that in GPA and MPA, those patients tend to do well. If this is a patient who is ANCA negative with cardiac involvement, that might be a patient where I would consider cyclophosphamide, because honestly, I don't know the impact of rituximab on cardiac manifestations in ANCA vasculitis, and this is a disease group where we have a lot more experience with cyclophosphamide.
And is there a role of mepolizumab in treating patients with EGPA?
I think there is definitely a role for mepolizumab in treating patients with EGPA, but probably not as a remission induction agent for severe disease. So mepolizumab in the randomized controlled trial was used to treat refractory non-severe disease. And really our experience with mepolizumab with vasculitis, for example, glomerular nephritis, is really fairly limited. So I'd say the primary role for mepolizumab in EGPA is a non-severe disease, either by itself or in addition to what we would consider a more classic therapies such as azathioprine, methotrexate, mycophenolate, etc.
And anything that surprised you about the development of guidelines, in particular for the ANCA-associated vasculitides? Anything that you learned, or any questions that the group had that you didn't find answers to that you'd like to know?
I think this guideline effort really highlighted for all of us in the room voting on, the guidelines, really where our gaps our knowledge are. You mentioned one of them. How long do we keep patients on remission maintenance therapy? We don't really know, and we would love to be able to provide guidance for patients and practitioners, on that question. How long do we keep patients on glucocorticoids? What is the comparative efficacy of agent A versus agent B? With rituximab for remission maintenance, how should we be dosing it? every 6 months, every 4 months, 500 milligrams, 1,000 milligrams. I think it's extremely exciting that we have these options, but we really do have gaps in knowledge in comparing one treatment to another and really understanding what's the optimal way to use these therapies.
Well, Sharon, thank you so much for this great discussion and on some of the clinical applications of the guidelines for ANCA-associated vasculitis. I hope that you're able to, that everybody listening is able to join us for the next episode where we will be discussing large vessel vasculitis. So stay tuned. Sharon, thank you so much, and I really appreciate your time.
Thank you.
I hope you all learned as much as I did about the management of ANCA-associated vasculitis from Dr. Chung and from the 2021 ACR Vasculitis Foundation recommendations. Don't miss the second episode of this series, where we'll discuss the latest recommendations about the diagnosis and management of giant cell arteritis and Takayasu arteritis. That's it for our show today. Don't forget to rate and subscribe to our show on Apple Podcasts, Spotify, or from your favorite podcasting app. You can also find all of these episodes and notes for our show on acronair.org. Until next time, please get yourselves and your patients vaccinated. And as always, stay healthy.